Hi, good afternoon, everyone. Thank you for joining us today. Those that are in the room, also those who are joining us by WebEx. In recognition of Poverty Awareness Month, the Office of Health Equity, Diversity, and Inclusion is happy to host a panel discussion on poverty awareness and healthcare implications. We are joined by representatives from Homeless and Travelers Aid, Street Soldiers, Serve Albany, and IPH, formerly known as Interfaith Partnership for the Homeless. I'm Angela Antonikowski. I'm Chief Health Equity, Diversity and Inclusion Officer here at Albany Med. And I'm also joined by Ishbel Correa Naves, who is our Program Coordinator. And we are happy to have our panelists here with us this afternoon. Before I begin with introductions, I just want to do some housekeeping for today. We are recording, so I would just like folks to be mindful of that. Please keep yourself on mute. And we will make the recording available when it is ready. There's also still time to donate to our clothing drive for IPH, so please drop off items in the Office of Health Equity, Diversity, and Inclusion in MS 114 next to the library. Ishbel, am I forgetting anything? Okay, great. Okay, folks. So today's event will include a keynote by Rebecca Cirillo, Program Director of IPH. Our panelists include Liz Hitt, Executive Director for Homeless and Travelers Aid. Madeline Mazaki, Rensselaer Co-Lead and Volunteer Street Soldiers. Woo. I love the support. And Jonathan Heinrich. Thank you. Director Serve Albany. Woo-hoo. Woo-hoo. So after our keynote, we will lead a discussion from the group regarding any questions, experiences as to how those of us in healthcare can effectively engage with communities experiencing poverty, communities experiencing homelessness as well. And with that, I will turn this over to Rebecca.
Great, thank you for having me, and I'm so grateful to be joined by a wonderful group of panelists who I hope will further speak to not only poverty in general, but the great work that we're all doing in the community. By no means do I consider myself to be an expert on poverty, so I'm going to do my best to just talk a little bit about what we are seeing on a day-to-day basis, specifically in our Albany County area. Okay, so when we talk a little bit about society, some of the things that come to mind is the culture that's created within our society. That culture can be across the country and then broken down into our smaller communities. So I think just even in our Albany County area, if we think about the differences between those of us who may live in more affluent areas. I know for myself, living in a more upper middle class area of Albany, the culture and the values and norms are going to be much different in the area of which maybe I live and am raising my children versus some of our areas such as the city of Albany, where families may have different values and norms, and the importance of keeping all of that in perspective and making sure that us as providers are never bringing our own values and norms that we were maybe raised upon in a way that we would make those biases against those that we're working with. So I think that anyone who's here today is making that commitment to do the really good work and to see folks as people first. And that's a lot of what I'm going to talk about in the next couple of minutes. So our community sometimes is very reliant on the resources that we have. And those resources, whether they're available or not, can often make or break some of the opportunities for the folks that we're serving in the community. We tend to, in our community-based organizations and a lot of the healthcare professions, we're seeing those members of our community who are considered to be much more vulnerable. So whether that be folks who are in minority populations or experiencing homelessness, single parents, not necessarily just single mothers, but single parents, folks with disabilities, and disabilities runs the gamut. It could be physical disabilities, mental illness, it could be cognitive impairments. And so those are the folks who need us to be their voice. They're definitely individuals who have less of a say when it comes to political decision making or policy decision making. So we as human beings, we affect our environment, but to be honest, our environment affects us and what we can and can't do. And we all have intrinsic values and worth, and we are all well intended, but the reality is that life happens, right? And I think the past 2 years has been a really important testament of that as we've all lived through this pandemic. So folks who may have been in very well-secured financial situations have found themselves in places where they're having to ask for help. Folks who are having to go and work multiple jobs, who maybe were used to living in a household with one income, are now forced to have two members of that household going out and working a job or even a second job. So I think it's been a real big eye-opener for us as providers, and having a little bit more empathy for those that we're serving in the community who were facing those struggles well before COVID. And so the other piece I just wanted to hit on is that our resources are often really scarce. So if we think about it, we're serving a large number of individuals who are all vying for the same resources. So you think of housing programs and the really specific criteria that folks have to meet in order to get into that one apartment that 15 individuals are all vying for. So that's the tough work that we're doing. So I thought it would be helpful to just point out some numbers from our previous year point in time count, which we're actually in the process of doing that point in time count for 2022. I think it actually started yesterday in some counties. But just to give you some numbers, because I think it puts a little bit into perspective, this is one night on a cold winter day in January usually, how many individuals were either in shelter or unsheltered. And these numbers are not on the dot, because the way in which we calculate these numbers is we're calling human service agencies and we're trying to get those numbers. So they're not accurate. So the numbers are probably much larger than what we see here reflected on this PowerPoint. So families, the number for one night, 633 individuals who identified at a family unit. 722 singles. Now this is just in the city of Albany. Of those numbers, how many were under the age of 18? 87 individuals. So then we try to categorize a little bit. So younger population, 18 to 24, there were 29 individuals, 606 folks over the age of 25. Now I know that's a really large gamut. And out of that number, 103 individuals considered to be chronically homeless. So these are individuals where it's not first experience of homelessness. This is ongoing, long periods of time of being unhoused. Just to give a little bit of perspective as well, I think it's really interesting that generally we see more males than females in our shelter systems. So you can see there's a pretty big difference, 572 males versus 146. So that's pretty telling as far as who we are also serving in our shelter systems. Pretty low numbers for individuals who are identifying as transgender or non-conforming. We are making a lot of progress in our programs as well, as far as making sure that our programs are that are welcoming environments for individuals who do not identify as either male or female. So Hispanic versus non-Hispanic, pretty large difference. Non-Hispanic, 651 individuals versus 71 who identify as Hispanic. And then the number broken down for other ethnicity, 295 individuals, again in one night, who identify as Caucasian, 389 individuals identifying as Black or African American, 7 is Asian, 5 is American Indian, Alaskan or Native, 2 is Hawaiian or Pacific Island Native, and then 20 who identify as multiple race. So again, we see that that largest number is serving our African American population. Just some really quick stats. I'm not going to go through all these stats just in the just to be mindful of time, but we are one agency, IPH. And so these are just some stats for 1 year for individuals we served in one community-based organization. So imagine the numbers that all community-based organizations are serving. So in 1 year, we served 207 individuals in our emergency shelter, 104 in our Morton Ave shelter, and 81 individuals in our medical respite shelter. We also have quite a few programs out in the Amsterdam area as well, so some of those numbers are reflected. We had 44 individuals who were housed throughout the year in our housing program within Albany County as well. And these are some big numbers as well. So we have some community-based organizations as well. So our Community Connections program in 1 year served over 1,000 unduplicated individuals. So that's a pretty big number in 1 year. So coming into our Community Connections and our Healthy Connections program, individuals are coming in for a gamut of services. They could be coming in to do laundry, taking a shower. They could have their mailbox there. They can come in for their breakfast and their lunch, so 2 meals a day, Monday through Friday. Case management services, a food pantry, a clothing pantry. They can come in to see our nurse. So they could be coming in for one or multiple services on a given day. So we're here to talk about how we can work together. We as community-based organizations working with our healthcare system. So we're typically tackling things like housing and basic necessities, transportation, childcare, education. But the work that the healthcare system is doing is just as important. So what we hope is that we will all look at the individuals that we serve in the community with a holistic approach. So keeping in mind trauma, and what does trauma mean? And how is trauma different from one person to another person? What can some approaches be that we implement within our practices where we take into consideration how we respond to individuals who have been through trauma? And also recognizing what could be a trigger for trauma. Some of those basic shifts that we can do in our practice go a long way with building relationships with the individuals we're serving. We also want to look at resiliency factors. So again, using myself as an example, if I'm an individual who's been through a traumatic event, I may have more of the natural supports and resources to help me get through that traumatic event. My responses are going to be much different than a lot of the individuals we serve who don't have natural supports, and so they're relying on us as providers to help them get through those situations. We want to create safe environments. We want to develop trust. We want to build on folks' strengths. You know, sometimes in our practices, especially when we're all working under strict requirements to see as many patients as we can see as many clients as we can see. Sometimes we're in go, go, go mode. And so we want to remember to just highlight whenever someone is making small amounts of progress. Know your community, know what's out there. And I think having panel discussions just like this is a way in which we can figure out who is working with us in our community and how do we point people in the right direction. And I think more and more what we're seeing is the medical practices are naturally embedding those social supports within their offices. More and more we see social workers in offices, nurse case managers. And so really picking up on that need to have those social supports within the healthcare field. So we really started to see this like in the terms of interdisciplinary practices in the 90s. So we've been doing this for a while, but as we all know that change is very, very slow, right? But I think it's helpful to acknowledge we've come a long way. We've come a long way with the partnership between community-based organizations and the healthcare system, but there's still more work that we can do. I think recognizing that everybody has their area of expertise, each person knows that area well, and sometimes there's some overlap. I think we were talking about this, some of us panelists, is there's overlap. Sometimes we realize two people are working on the same goal for an individual. So the more we communicate with one another, we can ensure that we're all working towards mutual goals. So again, holistic care, we want to make sure that we're treating folks, not just the physical, but the emotional, social, spiritual, and mental, seeing everyone as a whole person. Okay, in a matter of time, I was just going to give a couple of examples of some folks that we often see within our programs. Sometimes it's helpful to have a face. So I wanted to give one example specifically, an individual who was in our shelter program for almost a year, who had early onset dementia, and I was working really diligently with a neurologist, a very well respected neurologist in our community. And what I loved about that process was that this provider allowed for us to come into appointments with the patient's permission. And we had very open conversations about observations. And this provider was very careful about making a diagnosis before having the full picture, understanding the mental health component, understanding the environmental components, the substance use components, and really wanting to make sure before giving a very heavy diagnosis of dementia or Alzheimer's that the whole picture was really looked at while making those really important decisions. Another individual who stands out in my mind is someone who had worked their entire career at a job probably making more money than I ever will as a human service provider, but started to experience some healthcare issues, which many of us may just ignore those initially. We're working, we're going into work every day, and we got a little, something bothering us on our foot, and we ignore that for a while until it becomes extremely problematic to a point where we're managing the pain with some alcohol use, and it just escalates from there. It turns into loss of employment, which then results in loss of housing, which then results in a domino effect with healthcare issues, and now first-time homelessness. So these are the faces of individuals we're seeing in care. We're seeing individuals coming out of residential programs as youth and transitioning into adulthood and not necessarily knowing how to manage in society. We're seeing individuals who don't meet criteria. Criteria is a big one. Folks who are struggling with mental health diagnoses or substance use diagnoses, or maybe cognitive, and they don't fit in a quote unquote system. Office of Mental Health is referring that individual back to the Office for Developmental Disabilities. And so what's left is that folks are in shelter trying to sort that through. Where am I going to live permanently? So I think it's helpful to just understand that those stereotypes that often the community may have for folks who are experiencing poverty, it could really be any one of us. Okay, so what are things that those of you in the healthcare profession can do? I think of our partnership with the Whitney Young Health Center over at IPH and some of the innovative things that they are doing to serve a really vulnerable community. So I think of their WOW van. So they come to our agency once a week and they provide medical services in the community. So we take away that stigma or that fear of someone having to go into a medical office, and they come to our community. They're also in the process of looking at being able to do that from a mental health perspective as well, and I'm really excited for that opportunity. So I think the answer is to think creatively, right? To try to think outside the box, which I know is tough because we're all working under very prescribed circumstances, especially in the healthcare field, but have opportunities for language access services, or maybe identify if someone, their primary language is not English. Could we hook them up with a healthcare provider who speaks their same language? Any one of us would want to go to a doctor who we can communicate with. Consider flexible schedules. A lot of times our clients are the folks who are no-showing or showing up late for appointments. So just remembering the barriers for transportation and how difficult it is to get an MAS ride or to make sure that that transportation provider comes on time. Or think about how cold it was this morning and folks having to make a decision about whether or not they're going to wait at the bus stop for 20, 30 minutes in order to get to a doctor's appointment. So the decision may be, I'm not going to the doctor's today. While the rest of us, most of us have the luxury of getting into our car, warming our car up for a bit before we go to the doctor's. I think bridging gaps, another really big one that we're seeing right now is gaps in mental health and substance services. So we're looking to healthcare providers to help us bridge those gaps. Are you willing to prescribe psychiatric medication to hold us over until we can get someone into a mental health provider? All of those pieces go such a long way with the clients that we're serving. It also helps with that relationship building. Another plug is to look at those, I call them mom and pop pharmacies, right? So let's get away from those big box pharmacies. If we're using our Lincoln Pharmacy and our Maras and our Crestwood, those pharmacies get to know the patients we're serving. They deliver medications right to us. I know at IPH, our nurse, a lot of times, she's the one receiving those medications. She's ensuring that they're locked up safely. Because again, a lot of the folks we're serving, where are they going to safely put those medications to ensure that someone else doesn't get those medications in their hand? I think relationship building, I think a lot too, again, in the healthcare world, sometimes we're really tied to the computer and documenting and filling out all this paperwork. But sometimes something as simple as making eye contact with the individual that is in your office with you is really important, or maybe even allowing another provider to come into that appointment with them. I know, again, during COVID, it's been really difficult. We want to limit how many folks are coming into the office, but it definitely becomes helpful. We have a lot of folks, again, who have been through trauma. So the thought of coming into a doctor's office and potentially having to undress, or maybe seeing a provider that's a different gender than them, is very anxiety provoking. Being asked questions that maybe they're just not going to know the answer to, or just anticipating that maybe they're going to be reminded about their substance use or their lack of engagement with mental health treatment. Sometimes that alone they'll talk themselves out of going to an appointment. The other thing, little catch I want to put in there too, is those of us in the community-based organizations, we're the ones bugging the healthcare providers for paperwork. And so we recognize no one went to med school or no one became a nurse so that they could fill out paperwork for those of us in our community-based organizations. But bear in mind that sometimes those documents can lead to sanctions, can lead to folks no longer getting financial assistance from the Department of Social Services because they didn't have a medical form filled out, or because they didn't have the transportation form filled out. And so please bear with us as we're the ones who are excessively bugging you for those types of documents, but just to have an understanding of why we're doing that and why there's a sense of urgency for some of those things. Okay. Thank you.
Thank you so much, Rebecca. That was excellent, informative. A lot of conversation in the background that I'm getting that people are like, this is really helpful. Thank you so much for this. I'd like to welcome our panelists up at the front. And I'm going to probably step off so that the camera will orient itself. There we go. Great. Can everyone hear me? Okay, good. I think with that background and that information, this gives us a wonderful opportunity to be able to have some more conversation about how we can even more effectively engage with communities experiencing poverty, homelessness. And so I'm hoping we can take as a sort of first opening conversation, I'm hoping each person can share a little bit more about who you are, what you do, and what your organization does. Why don't we start?
I need the microphone?
Yeah.
Oh. Thank you. My name is Madeline Mazzacki. I am a volunteer with Street Soldiers. Street Soldiers is a local grassroots community-driven organization, and we provide services to people that are food insecure along with those that are unhoused. So that's my volunteer gig. Full-time job is I'm the director of operations for an organization called Miracle Messages that ties right into what Becky was talking about with rebuilding social supports and providing people with an ability to see their worth and to know that they can be a friend to someone. Definitely in this world of unhoused, pretty much every day.
Thank you. And I'm the executive director of Travelers Nation Society also known as HATAS. We're on the phone every night with um, which can be as frustrating for them as it is for us, just to be honest. Oftentimes we're on the phone for social workers, homeless people, or should say unhoused people, are coming in now to ED. Of course, that's significant and challenging for everybody. Mandated to collect certain information. In the shelter, IPH, or the Capital City Rescue Mission. If someone has been diagnosed as having COVID, quarantine, that means a hotel room. Of course, you don't want to put people out in motel rooms without support. So when it all blew up, March of 2020, I'll never forget, we were on the phone with AMC. It was a Friday night. Nobody knew us. But we figured it out together. Because then we thought about transportation. How are we a person from the hotel? Tell the cab driver that this person likely had this new virus that none of us know anything. Most of us know very little about. So we run that program. That's called the Homeless Hotline. That's been operating since 1983. For this past year, there have been just over 7,000 people contact that hotline. Last year, there were, 2019, there were about 3,400. And this past year, just over 7,000. So COVID, of course, just turning that, just doubled. Say, everything happening. Code Blue, you've all heard of Code Blue. That was started back by us back in 2010. But, I'll go with that. We're calling the alert. Providers are all on the page. IPH, Capital City Rescue Mission, the outreach band, making sure everybody knows and call. It does mean something when it's night, because oftentimes people that can't be sheltered can be sheltered if it's Code Blue. So kind of not the rules go out the window, but it's more relaxed because we just want to injured or possibly perish, which does happen. 4 units of housing. We have a team at CDC. They often are here at all the events for me. So it's not a big agency, actually. It's only about 30-something. Spread over about 3 or 4 sites. I'll go for not to belabor what I already addressed, but I think, IPH is definitely an agency that looks at not only serving the whole, folks looking at housing, healthcare, job opportunities, after modeled actually after this mission, we're helping folks basic job skills, having a reference to have a nurse on site now, so offer some basic health opportunities, but start conversations. Let's get you it out there. The hospital. So I think again, the agency is looking at what's the next program. Someone asked earlier about the change in our name. That was largely going from Interfaith Partnership to IPH. We really wanted that to reflect that we are offering so much beyond it.
my name is Jonathan Hendrick. I'm the pastor of Church Christ Church Albany, and we have an initiative called Serve Albany. And the way that we work with this is kind of two main ways. So one, we'll work alongside different organizations like this and hear their amazing work that they're doing and hear the amazing needs. And almost always, one of the things that's limiting what they're able to do is that they don't have enough funding, they don't have enough volunteers. And at the same point, there's lots of folks in the community that hear about needs like this, and there's something that stirs in them. They want to help, and they're not exactly sure how they take those steps to get involved and serve and give. And so we try to take those barriers down to make it easier to serve and volunteer at organizations like this, which is a huge deal. And then we've also become a bit of a networking catalyst for bringing different groups together to have conversations. And so we'll bring different organizations that sometimes get easily as get busy and siloed and try to bring them together into the same room so that we're having conversations together and that we can work on these bigger issues collectively as organizations and not just individually.
If you could just take a moment. The biggest things you wish people knew about poverty.
All right. I guess the biggest,
It was
no,
a big class press subject.
okay, can you hear me now? All right. So, what was the question again?
We want people to know.
So, I mean, I think for me, the thing that was eye-opening when I started volunteering with Street Soldiers about 4.5 years ago was that anybody could be on either side of that table. Like, it can happen at the drop of a hat to anybody. And the circumstances and the reasons around why somebody might be in line to have, because they need toothpaste or pantry items or a hot food or a Coke, are so varied that I think that we just need to stop judging and we just need to look at the person and we need to just listen to their story. We need to believe their story. We need to believe their story. I think that I really truly believe if we just listen, we'll learn so much and we'll understand why people are either houseless or food insecure.
So just the term poverty, it's kind of overwhelming because it can be so too different. So everybody here, I think, might think a little bit different, but it might be under-resourced living in poverty. Now there's a formal definition for poverty, right? In terms of income, 50% of this, 30% of that. In general, when people reach, which is how we term that, if at all possible, it can be very complex. I think we often fail to remember, because if I'm speaking with someone about their housing, I'm thinking, oh, they're very interested in the conversation, this impacts something very important to them, where they live, et cetera, but we all can do that. So just to kind of always pause and say, how many places that mom in order to meet with their housing navigator, maybe to stop and pick up some food, go to the it's daunting. And then got to pick up something for dinner, need to get home, try and help the kids do a little bit of schoolwork if at all possible. Often just underappreciate how difficult this can be. We ourselves are often part of that problem. None of us like to think of ourselves that way. But about 5 years ago, we worked with all of the local shelters. Just say, let's just have one form that people fill out one time, but that wasn't the case. Every shelter had its own unique process and documentation. I remember meeting with some of the shelters. We just happened to be kind of put in charge of coordinating this, nothing special about that. And they said, but we have the best intake form out there. Like, I am sure you do. It doesn't ask anything that the mission doesn't need to. IPH and Mission and Mercy House and Malonga and Schuyler Inn and St. Catherine Center for Children all need the same information. Your name, your date of birth, how old are the children? Can people get up and down the stairs? Yes, there might be one or two questions which are very specific. Let's just all set down our pride, I guess, for a moment. Just say, how do we make it easier for the person? So that turned into what we call coordinated ed. Far from perfect, we're on version 14, but we all agree we can use this same document. And when people go from shelter to shelter, which they often do, we call it the shelter shuffle. Don't make them start again. Share the records with the other place. That still isn't happening. Not 100%. We're getting better at it. But we often ourselves create these obstacles. Not for any particular reason. We've gotten much, much better at it. But we just, if we pause and think about the obstacles put in front of us, appreciate their lives with trying to manage children, that would be significant. And much more than that, but I think would be autonomous is really so allowing individuals to make decisions best for either self as an individual or, as I kind of mentioned previously, is kind of taking our own helps us be a little bit more open-minded to how we then put treatment plan. Back to that concept of recognizing those really small progresses. So maybe the office now has finally agreed to take an over-the-counter medication. That's the individual for years who has said, no, I'm going to manage this. Maybe has found some other ways to self-medicate. So any opportunity where you recognize that some decision they feel is best for them, and then taking it one small step at a time. And I think not, to Liz's point too, is not stereotyping, seeing folks as other than with value. Hopeful, we are making some headway. That's when we really start to lose our opportunity to help individuals.
And one of the things I've learned from working with organizations like this is that the idea of homelessness, that this is a solvable problem. It's a very complicated problem, but it's not something that has to exist in a society like ours. So one of the, I hate the phrase, it is what it is, where people like, will look at an issue like this and like, well, there's just some guy, there's some woman, there's some family, and this the situation they're in, and they just, we're really, we could send them to a shelter, so there's not really much we can do. That's not the truth. If we all work together and bring these systems, there's ways in which see someone who's homeless, our thought should be, it should stir us to the point where it bothers us. That this is something that doesn't have to be, and we each have a role that if we can figure out how to play and work together and work with these organizations, it's something that it's possible to eradicate.
Do you interact with children in poverty? And if so, what are some of the key challenges when
So, we work with every year closely with Catherine Center for Children, Tyler Inn, other places where primarily. Question?
what are some of the key challenges when
So if you're homeless and you're 5, that's a lot different, or unhoused and you're 5, that's a lot different than being 35 years old and housed. None of those two people should be unhoused. But when children are in that type of situation, under the age of 5, it cracks the foundation. Doesn't mean you can't fill it in. Doesn't mean it's not repairable. There's a monumental shift that happens. Anyone that has children certainly understands that, because everything is happening, especially in brain, other places, is background. Between birth and 5, those critical years, if a child is out a permanent place to live without that stability, and children are very resilient, had people in our waiting room, the parents are sobbing, everyone else is very distraught, and the kid's just playing with something, and they seem quite okay. That can often be the case. Children can manage these things as long as there's support. Fortunate here, St. Catherine Center for Children, Skylar Inn, and Catherine's, they've been doing this a really long time. They have their systems. So having entities specifically designed for dealing with children, education, they have a different level. So that's very important.
I don't really have much to add. I mean, for street soldiers, when we them are, they are definitely poverty, food insecure. And so we try at Street Soldiers to just provide them with a nice environment to come to. They can take their items for themselves if they want. We provide, fresh fruits and vegetables, which a lot of times is lacking in the diet of children that are, food insecure with their families. And so we just try to provide just a safe environment for them when they come. Do you want to just, put it in your hat? I mean, it's Friday night, it's cold, winter, dark, and people are coming through the line with their children, with their infants, to get the items that they need. So they're there because they need, and we're there to make sure that they get. We do what we can when we can, but we also want to make sure the children are safe and they don't feel embarrassed that we're giving them items.
So, and I think this comes up quite a bit, so poverty. To get people to change their perspective.
So that just in my personal, it is a host of different things all happening, whether it's through school, hours, or we all on the same page, trying, making an attempt to type of issue. That's one of the most complicated. Have quick response to that. I don't know if it
talk about how our society why is it that when are folks sleeping? When are individuals sleeping? How can we possibly ask that someone's health, sure they have a roof over their children? And so I think of these situations, again, could be that domino effect of people have the right making the decisions at that time they feel are best, but then those have consequences. And so we're having to choose, do I go to a doctor's appointment? Can I call out of work one more time? Can I take the time out to be going to my mental health appointment? So I think a lot of it comes down to choice. At some point, Jonathan mentioned, some of this is fixable. So we start looking at how do we make services more flexible? So if providers only operate from 9 to 5, which is also the time that most folks are going to work. I think COVID in some ways has resulted in, opportunities to do things virtually, which would be great for folks who have those resources, folks who have a phone or access to a computer. So again, not to bring it back to myself, but could I take an hour lunch break at work to jump on a virtual meeting with a therapist if I needed one? I sure can. So I think these conversations are about looking at how we continue to look at change so that we can ensure that folks don't get deeper into situations that they then can't figure a way out of.
Pretty simple, yeah. Well, if you know someone and that's their kind of judgment is that this is all just their own personal consequences, or if that's something you struggle with, then you need to get a hold of street soldiers and you need to volunteer on a Friday night and keep volunteering on Friday nights. And once you start getting to know the stories of the individuals that are there for the kids, it will change. But as long as it's homeless people out there somewhere, it will always be a little stigmatized. Once it becomes individuals that you know their names and you take the time to listen and tell their stories, the whole ballgame will change. And we need as many people as we can. And that's why I always tell me, all of these organizations need volunteers to do, but everyone needs to volunteer. They need that themselves. That's the only way that our hearts and our own personal biases will change when we get involved in the solutions.
Probably serves to and they are generally structured. And these are things that some influence. Can you talk a little about COVID?
My answer's short. I'll do it first. My answer's short because it did really impact. We didn't miss a beat. We were always in the park. We changed how we did things. We, maybe had bags to hand out to people. We had less volunteers, but the need was there, and of course, the need was greater. So for us, things didn't really change, and now people are starting to feel more comfortable and volunteer-wise out. So we did lose some volunteering, but we have an Amazon wish list, and Renee, who's our founder, the UPS guy was just constantly on cycle, just constantly at her place. So we really didn't miss a beat, honestly.
So we just lifted the eviction moratorium, or the state say lifted that. What's going to come from that is just, I don't think really almost any have any truth. Got some numbers, and we know how many cases there are. That's an outcropping of COVID. COVID for us been a lot of strain. I'm sure it did here. That's certainly what we heard on the phone, chatting about someone that say, and I'm not sure employers that we're appreciating what that will mean in terms of wanting to go into this profession. And what's that gonna mean 25 years from now? That's kind of concerning. But that's strain day-to-day people serving me. They've held up. There's, we lost very few, but for us, that's been some impact. Just drilled at how well they've held up. But I do have these things longer term. And then for the people that you serve directly, because of the moratorium and some other things, it could have been still there handing out food, stay in their units for the most part, increased number of contacts at the guessing and stuff like that. But for us, we're still going to see it. Of the folks that shift in kind of connectivity. Our shelters may have been operating in a, individuals could still stay, they could stay today. What they lost was the ability to be able to go to the ability to go to day programs or mental health group. That reason to get you up and moving each day, to give you structure and routine in your life. A lot of what we've heard serving is, I've already felt really isolated. I didn't think I could possibly feel. Even you think that someone to say in shelter, you're in congregate care, yet you still feel. So we have to get really creative. I mentioned figuring out that's to at least be. So I think those are some of the challenges is individuals weren't seeing their therapists, doctors, psychiatrists. So having to adjust to that type of part for a lot of it. Again, they lost that kind of staff and get moving each day and kind of have somewhere to and have that sense of accomplish something.
I guess in closing, could each person just, what is the takeaway that you for healthcare folks to move forward on?
Say, again, beyond your professional world, I would take time to get involved on a personal way in some of these organizations. So find a way to schedule a visit with one of these organizations. I'm sure all of them would be happy to give a tour, be happy to introduce you to ways in which you can volunteer. And and every single one of them, they need skills and they need money. And so if you have skills and if you have really be a big part of moving this forward.
I think just that we are all working. Right? We all want health outcomes. We all want to see a reduction in their ER, ED, minimize readmissions into the hospital. Like, we all have the same goal in mind, and we all have a different area of expertise in how we could try to tackle that goal. I just want to thank those of you who continue to choose to be in the healthcare field, especially over the last couple of years, and to know that our value is appreciated and is service providers really value your role in the total picture when we're working. Very humanized. What else can you?
Every attempt to see that person, which may be extremely challenging, absolutely falling to pieces Friday night when the sirens are wailing, beds are full, it's under madness. So just every moment you could possibly pause to say, okay, this person's making me bananas, but it's because they really need something from other providers. Let me see if I can just continue to try and figure out what that may be. I just can't state how incredible.
I'll echo that. I mean, many things for healthcare. The thing that I'll just mention is sometimes when someone does come into that, and it's possible that they've been disconnected from family for a while. My full-time job outside of my volunteer work with street soldiers, you go take a look at miraclemessages.org. We can help someone who comes in unhoused. They have an ID on them, maybe they don't. You know, if we could just get this person with family, maybe family will be the answer. And maybe they'll no longer be houseless. And so that's what Miracle Messages does, is we try to help people that are currently unhoused or have previously experienced houselessness, reconnect them with family, rebuild their social supports, because we all heal in community. And so that's part of what we do. So again, just looking at the isolation, how can someone heal better, and maybe they could heal better by having family back to our circle.
Thank you so much. So really, take away, show up, our tourism, really.
May I have your attention, please? Fire alarm testing will be conducted in the Everett Delta building. Please disregard all alarms further noted. And may I have your attention? Fire alarm testing will be conducted in the Everett Delta building. Please disregard all alarms further noted. Thank you.
All of us working together, share goals, with empathy, seeing that person in context. Thank you all for your energy, your time, to share and
Thank you for having us.
thank you everyone on the call.
Figure out how to turn it on.
Oh, my goodness. Nothing more dangerous than a hot one.